Hi, my name is Alicia Silva. I am going to go over case 4 and 3 of our connections of Unit 4. So let's start with case 4. So case 4 is a 57-year-old woman presenting to the ER for progressive fatigue, progressive weakness. She is tachycardic, and on blood work, we did note that she had a low hematocrit. We did consult a hematology consultant, and they looked at it and they said they suspect megaloblastic anemia. So when we look at that, we were looking at any probable deficiencies, either be vitamin B6, iron deficiency, or vitamin B12 or cobalamin deficiency, to give us the reason why she is now having megaloblastic anemia. So upon further research, we did see that the megaloblastic anemia is one that is caused because there's a deficiency in cobalamin or B12. And since cobalamin and the folic acids are both used for DNA synthesis, we look more into that. And so the main factor or the main role of folate is to donate a methyl group to the DNA, and then the vitamin B12 is a cofactor in that it uses the methyl tetrahydrofolate to be reversed and changed back into tetrahydrofolate. That is done so that the DNA can do cells, and during the cell cycle, the cells go into phase S, and then from there they can progress and mature. So when there is a deficiency in the cobalamin, we see that the cell cycle stops at S and the cells do not mature, and then they lead to cell death or apoptosis. This is a concern because with them maturing, we also see them go from normal cells and then being translated over to homocysteine that gets changed to methionine. If the methionine is not present or it is in lower amounts, the homocysteine numbers are elevated, and when that is elevated, there is more risk for heart disease. So in this case, she presents also with a 2 out of 6 heart murmur. She is fatigued, and she is a little pale. So again, leaning back to the anemia, and that is a problem with the pyrimidine metabolism because the tetrahydrofolate is being oxidized into dihydrofolate, and that inhibits the thymidylase synthase from actually being able to convert that into more of the pyrimidine. So that inhibits the pyrimidine synthesis. We didn't see an iron deficiency be this issue. Yes, it would cause an anemia. However, the red blood cells would be normal in size. It's just less amount of them. And when we see this anemia, the megaloblastic anemia, they are larger in size than a normal red blood cell. So that's one of the reasons we don't look at iron as a deficiency. Vitamin B6 also would not be one of the deficiencies because it would be needing to be correlated with the B12 complexes as well, vitamins. So B6 and B12 are together. But she also is not presenting with dermatitis or scaling of her lips. She's not having a history of depression, confusion, weakness, weakened immune system, or having a swollen tongue. So when we're looking at blood work, we would be doing a complete blood count, looking at the red blood cells and its functions, a reticular count to see how many are healthy red blood cells from the bone marrow, and then we do a blood smear, a peripheral blood smear, just to make sure that we're looking at the size of the red blood cells. For case 3, we're seeing a 47-year-old man with a painful right toe. He was diagnosed with gout, and with blood work, we see an increase in his plasma urate, and the urinary uric acid is less than the values that we have. So with gout, it is usually characterized by painful joints, usually the big toe, and inflammatory arthritis, which is very painful. So gout is caused by an increase of uric acid in the body, and so this happens when the body is making the uric acid and the purines are being broken down. And when the purines are not able to be excreted through the urine, they build up in the body, which causes the hyperuricemia. And if that, again, is not regulated, we see the buildup to cause a monosodium uric acid stone to form, and they usually lead off and then go into one of the joints. So more than 90% of our patients with gout have the hyperuricemia, which is again identified as the plasma urates are elevated, but it's not being excreted through with the kidneys in the 24-hour period. And that can be just because he might be on some medications, or there's an underlying renal disease that is not allowing us to excrete the urine with the uric acids. And so that's why this is an overproduction of the uric acid, an under excretion of the underlying effects that is going on with the uric acid. So it's not an overproduction of the purines, because we would see both of the elevation in the plasma and the urine, and that's usually with the Lesch-Nyhan syndrome, and with that we usually see patients again have both elevated, and it's an X-linked recessive disorder. With that as well, we would also see some other signs of some motor dysfunction, some cognitive deficits, and behavioral issues like self-mutilation. This patient does not exhibit any of those, so we can cross out overproduction of purines. Another is an overproduction of purine, decreased salvages of the purines, so that can be an explanation. Excuse me, I misspoke. So it's also not a decrease of salvages of the purines, because again, going back to an overproduction, Lesch-Nyhan syndrome is a big factor, but we're looking at the salvage pathway. So then we look at a few enzymes that would be the cause of a action that would be irreversible. We would be looking at the adenine phosphorybosyl transferase and the X-linked hypoxanthine guan phosphoribosyl transferase, which all get hydrolyzed by the PRPP, which is the phosphoribosyl 1 pyrophosphate. Oh my god, that's such a hard word to say. I'm sorry. And that all is trying to convert that into the reaction. Again, this is all linked to the X-linked recessive disorder, and it decreases the salvage of the purine. So again, it can't be that, because we would see an elevation in both the plasma urates and the uric acid. And he also was drinking 4 to 5 liters of soda a day from diet to normal, which is very bad in general. He should not be drinking that much, but because of the high fructose, that is causing him to exhibit more gout, since he could have an underlying hereditary fructose intolerance, and since the sugars are not being utilized as effectively, he is causing the sugars to convert to lactate, which is increasing the renal absorption of the uric acid, which decreases actually the excretion of it. So then that causes gout to be more proliferant. There are some medications that we can use to help with managing it. In his case, we would use some NSAIDs to manage with the pain. We would also possibly use allopurinol as a medication, so that we can decrease the, it's another medication. That one would decrease the production of it. So he's actually producing the underproduction of it. So for him, he was overproducing it. So we want to use a medication called probenexid, because he's overproducing and not excreting it. We want to excrete it out of his body and give him some NSAID. And also have him not drink so much soda. That is a lot. And have some more water in his life to counterbalance the 4 to 5 liters of soda that he is drinking.